Hello, and thank you for attending my poster presentation titled The Effect of Exercise Interventions on Gait Outcomes in Individuals with a Lower Limb Amputation, a Systematic Review and Meta-Analysis. Approximately 7,400 individuals undergo a lower limb amputation each year, with this number expected to rise in the coming years as a result of an increased incidence of diabetes and peripheral vascular disease. The ability to walk is the most important factor contributing to quality of life in this population, and as such, intensive rehabilitation is essential. However, even after completing a rehabilitation program, over half of individuals with a lower limb amputation will experience a fall, with these falls occurring primarily while walking on even surfaces. Rehabilitation is a lifelong process for these individuals and can be broken up into different phases, each with specific objectives. The subacute phase begins shortly after amputation, continuing to roughly 6 months. This phase includes maintaining mobility, strengthening the lower limb, fitting a prosthetic, and beginning balance and gait training to recover activities for community reintegration. At the 6-month point, there is a transition to the chronic phase, which consists of continued prosthetic, functional, medical, and emotional support to meet long-term goals. A quantitative synthesis of the literature has not yet been conducted to inform clinical practice. Therefore, the goal of this study was to conduct a systematic review and meta-analysis evaluating the effects of exercise interventions on gait outcomes in people with a lower limb amputation. To do this, we completed a search of 6 electronic databases with search terms related to exercise intervention, lower limb, amputation, and gait outcomes. The search, screening, data extraction, and methodological assessment was carried out in duplicate by 2 independent authors, and a consensus was required for each. A meta-analysis was planned a priori, evaluating primary gait outcomes of each included study. Results were pooled across studies to generate standardized mean difference. Planned subgroup analysis identified a priori was recovery phase, that is subacute or chronic. Our inclusion criteria were randomized controlled trials examining the effects of exercise interventions on gait in adults with a unilateral or bilateral amputation at the transtibial or transfemoral level and using a prosthesis for walking. The breakdown of article inclusion and exclusion can be seen in Figure 1. After review, 14 articles were included in the final synthesis and analysis. 4 studies evaluated the subacute phase, while 10 examined those in the chronic phase of recovery. Of the exercise protocols included, 13 were multi-component, consisting of 2 or more elements, including gait, balance, strength, mobility, or aerobic training. The remaining study included solely strength training of the hip abductor muscles. A variety of methodologies were utilized, including proprioceptive neuromuscular facilitation, or PNF techniques, exercise-based video games and virtual reality, dual tasking, and mental practice. Interventions were 15 to 60 minutes, 1 to 7 times per week, for 2 to 16 weeks. Individualization, intensity, and progression was not consistently reported across studies. Methodological quality of reporting assessed by the Pedro scale was rated as good on average. The overall results of our meta-analysis demonstrated a significant moderate improvement in gait following exercise interventions, and subgroup analysis further revealed a small improvement in the subacute phase of recovery and a moderate improvement in the chronic phase. This last point is important to highlight, as previous literature found a plateauing of improvement in physical function in people with a lower limb amputation at 6 months post. However, based on our results, we can see that significant gains can be made in walking ability even years after the amputation has occurred. Unfortunately, although benefits to gait were seen in exercise interventions of at least 2 weeks in length, the variation in duration and frequency and lack of reporting on intensity, personalization, and progression of included protocols precludes a clear recommendation for maximizing these gains. This highlights an area for future work and the need to be thorough in the design and reporting of studies of this nature. Finally, interventions such as dual task training, virtual reality, and mental task training show promise for gait rehabilitation. However, additional research is needed to confirm these effects and the clinical feasibility of these interventions. Thank you for listening to my presentation.